So welcome everybody to session 3 of UK Biobank Scientific Conference, which is focusing on health outcome data. So this session will review the value of primary care data for research purposes and the steps that are being put in place to access these data. So this is important because primary care data massively increases the number and the types of health outcomes that researchers can investigate, and UK Biobank has spent years trying and only partially succeeding in accessing primary care data for our 500,000 participants. So it's great to be able to discuss the progress that's been made in this regard a bit more in this session. And we'll also discuss the rationale for UK Biobank's new research analysis platform and how researchers can access the data. So we're joined by 3 wonderful speakers and 2 panelists in this session. Dr. Michael Chapman from Health Data Research UK, talking about NHS digital data. Dr. Ben Goldacre, talking about the Data Lab and OpenSAFELY from the University of Oxford. And Dr. Mark Effingham, UK Biobank's Deputy CEO, talking about UK Biobank's new research analysis platform. We're also joined by Professor Smeeth and Professor Dame Clare Gerada on the panel a bit later on. So just a bit of housekeeping, a bit of housekeeping before we start. For those of you who are new to this session and haven't seen the previous 2 sessions, you can move the various panels around on your screen by just clicking on the right-hand corner. And please do, if you've got questions to any of the speakers, do pop them in the chat through the Q&A thumbnail at the bottom of the screen or through the Ask Question window. And I'll try and make sure that those questions are put towards the panel. If you run out of time, then somebody from here will try and answer them the best that we can. And just if you want to watch this later on, this will be available either tomorrow or Friday on-demand content on the website. So without further ado, I'd like to introduce Dr. Michael Chapman from HDR UK, who is going to talk to us about the role of NHS Digital in providing electronic medical record data for research use. So over to you, Michael.
Late of Health Data Research UK, because contrary to what it says on the slide, which I should have looked at more closely, I am now Director of Research at NHS Digital, which is the central data and technology body for the NHS in England. My role there is to try to make it easier for UK Biobank and for other legitimate users of the nation's health data to access it for research and for other purposes that are going to improve the health of the nation. And I was asked to come and to talk to you a little bit about central access to NHS records data. And I thought, you are an audience of people interested in UK Biobank, of users of UK Biobank. I could tell you what wonderful progress has been made, all of the data sets that are available now through UK Biobank. Because in fact, if we look nationally and if we look internationally, UK Biobank is an absolutely incredible resource, almost unparalleled, and it's a huge credit to Rory, Denai, and to the team that they've managed to assemble that. But I suspect what you are interested in as users of UK Biobank is not the things you already know about, it's what are we doing next? What are the difficult things and how are we working to make those better? So I thought I'd talk a little bit about that. And the key message I want to get across, I work at NHS Digital, we do this work across the system. We do it for research, but we also do it, in fact, primarily we do it for the benefit of the NHS, for planning the NHS, for operating the NHS, for commissioning health services and for improving health services. And the message I want to get across today is when it comes to collecting and using the country's health data, we are all of one company. The lessons of the past are that separate, fragmented initiatives to do this don't work out. We spend a lot of time, we spend a lot of resource, and often we create partial solutions. We create solutions that cover some of the need, they cover some of the country, they cover some of the patients. They don't give us the full picture that a study, a resource like UK Biobank, which stretches across the whole of Great Britain and which stretches across our population, they don't provide the resources that needs. And this is part of the reason, I think, why UK Biobank has found it so hard to make progress on things like primary care data. So I'll talk a little bit about what we've been trying to do. I'll talk about what's not gone well, and I'll talk about what we're doing to recover from that. And then hopefully we'll hear from Ben, who's also got a lot of expertise in this, and then we'll be able to have a good discussion. But I'm aware of time, so I'm going to move on. And I'm going to start with a quote from the UK Biobank protocol. So this is from March 2007. So the purpose of this, so UK Biobank is not just a resource of samples, it's not just a resource of the baseline assessments and the ongoing interaction with the cohort, it is also a resource of follow-up data through health records. And UK Biobank, I think, is an incredibly efficient resource as well. The amount of money that goes into UK Biobank compared to the outputs, it's an absolutely brilliant deal for the country. And part of the reason why it is such a good deal is it doesn't try and duplicate things that are happening elsewhere. So we can follow up participants through NHS records if we can get that right. Where are we on that? This is adapted, let me say, from the UK Biobank website. There's a nice page that summarizes the health outcomes data available. And you'll see that actually, if we look at hospital inpatient data, if we look at cancer data, if we look at death data, there is data available. If we look at primary care data, as many of you will know, we've got about 90% of the cohort, but only if you want to do research on COVID. Now, I don't know who's been doing research on things other than COVID for the last couple of years, but we are going to need to move on. If you're not doing research on COVID, the figure on the website is about 230,000 participants, so that's something like half the cohort, a bit under half the cohort, but that only goes up to 2016 or 2017, depending on which GP system you're registered with. So we need to talk about that. I'll come back to some of the algorithmically defined health outcomes, some of the first occurrences of medical conditions, some of the derived data, because I think one of the places where we might be able to do things better as a system is by joining up on that. We shouldn't have lots of people doing that separately. We should be able to do that as a country and share what we're doing. So I want to say a few words about that. But what I really want to talk about is primary care data. Sorry, there's a bit of a lag on this massive screen I keep hitting. I'm not just waving my arms over here. So primary care data, what's happened? I should give perhaps two trigger warnings here. First of all, I work for an organisation that's England focused. So I'm going to talk about England. I'm sorry about that, but if I talked about other countries, I would be well outside my area of expertise. I'm also afraid for those at UK Biobank who have been working on this for many years, this may bring back some slightly painful memories. But to cut a long story short, UK Biobank has about the best consent you could get. I recognise that we ask difficult questions when people come to us for data. UK Biobank put a lot of thought, a lot of work into the consent from patients. And that allows them to receive all of the data that we can see on this slide. When it comes to primary care data, there was not, when UK Biobank started, and there still is not, one national place where one can go and collect data for named individuals who have given consent across the whole of England. So a lot of work went into asking for that data from practices, and it was going quite well. And then it stopped going well because people asked some questions, totally reasonable questions, the sorts of questions you expect when you have 6,500 or so, somebody will be able to give me the accurate number, different GP practices, all of who are individual data controllers responsible for the data of their patients. And what's encountered is it is almost impossible to get beyond this sort of 50% or so mark. The amount of effort required to get to absolutely everybody, to get up towards 90% even, is absolutely enormous. And as well as other difficulties encountered, it has not been possible for UK Biobank going individually from GP to to get this full data set. So what changed during COVID? Because, thank you, Claire, that's very helpful, 6,000 GPs now. I mean, it's getting easier, but still difficult. So what changed during COVID? Why have we been able to get to 90% during COVID? Well, what changed is the Secretary of State wrote a letter under his powers, under the Control of Patient Information Regulations, to all general practitioners using two of the main GP IT systems, and said, this is an emergency, I require you to share this data with UK Biobank. And that takes away all of the worry, it takes away all of the concern that a GP partner may have that they're giving out data about their patients and they may not be doing it in quite the right way. Totally understandable that people have those concerns. What it gave them was the ability to do that with confidence. And suddenly we're up to 90%. So what we need, if we want to do this beyond COVID, is some kind of mechanism that allows the data to be taken under some form of central control, those decisions to be taken centrally, not by 6,000 different organisations, but by a small number of organisations, and done in a safe, transparent way that everybody can trust. So we tried to do that over the summer, and many people will remember it's a programme called GP Data for Planning and Research. And I would love to avoid talking about it, but I think I need to admit the fact that that didn't go very well. This is a slide of the number of people opting out of the use of their data for planning and research in the NHS. And what you see is an orange line, which is the cumulative opt-out rate. And that goes at the start of May from just over 2.5% to, as it is now, just under 5.5%. And that is the result of communication and a national debate, I will call it, a national discussion about this plan to use GP data in this way. It wasn't communicated well, we didn't take the profession with us, and we didn't take the public with us. So that's the challenge. We need to find a way in which we can crack the nut of not having 6,000 odd different organisations having to make these decisions, but do it in a way that the public trust, because right now it is quite clear that the public, that the professions don't necessarily trust the plan that we came out with in the summer. So how do we remedy that? This is the text from a letter from Jo Churchill, at the time was the Minister responsible for general practice. She's Parliamentary Under Secretary of State. She wrote in July to all general practices saying that while we were continuing with the project, we are still committed to collecting this data. We're not going to have a start date. We're going to take away any deadlines from it. And we're not going to start again until we've done 4 things. We've sorted out those opt-outs. That's second on the list. We've done that. We're going to allow people to delete their data. They're going to be able to opt in and opt out of this as they want. We will have a trusted research environment, and the data will only be accessible to a trusted research environment unless consent has been given. So we're going to talk about UK Biobank's research environment. We're going to talk about consent. And once we've done much more communication. So that is the task now. That is what we're working on. And we will be working on that over the coming months. There will be more communications coming out about that in the near future. And I'm sure we'll want to discuss it. But we have some work to do to recover trust. We've got a plan to do that. And if that goes well, that will give UK Biobank what you need to use GP data beyond COVID. I'm aware, probably out of time. I will stop there, I think. I'd like to come back to chat about some of the cancer data, because I think there's things we can do there, and perhaps about some of the algorithmically defined health data sets. But let me leave it there, and we'll cover those things during conversation. Thank you very much.
Thank you very much, Michael. That was great. In the interest of time, I'd like to move on to the next speaker, who is Dr. Ben Goldacre. He runs the data lab at the University of Oxford, and today he's going to talk in his capacity about OpenSAFELY, that has lots of data on linked primary secondary care for research purposes. So over to you, Ben.
And what I wanted to talk about was a related set of projects around getting better access to primary care data. I think most people here will probably be aware of the power in routinely collected electronic health records data, but just to reiterate, the GP record in particular in England is the jewel in the crown. There's one row for every diagnosis, every test, every referral, every prescription, and so on. And that can be linked on to hospital admissions, outpatient visits, A&E attendances, and so on. And this is an extraordinary resource, partly because of its depth, its granularity, partly because of how longitudinal it is, and that's a testament to how ahead of the game the NHS was at computerising electronic health records. We started in the 80s. By 1996, 96% of practices were fully computerised. But it's also powerful because we've got a very large and very diverse population. So there are other countries now that are catching up in terms of the quality of their data and its accessibility. But we've got pretty close to 60 million patients in England, and we've also got a very ethnically diverse population, which means that the results of analyses done in NHS electronic health records data are actually very broadly applicable around the world. In OpenSAFELY, we set out to build what I think remains possibly the world's largest electronic health records research platform. And we did it at the beginning of COVID, 6 weeks from project commencement to first analysis out, a paper that went on to be published in Nature looking at factors associated with death from COVID-19. And we did that for two real reasons. Firstly, pandemics call for bigger, faster data. So conventionally, researchers work on intermittently extracted records for only a few million patients through a conventional research data service. And that data is commonly many months out of date when it becomes available for research. If you're evaluating a new rapidly arising cause of death like COVID, then you need data really quickly. And COVID-19 was a new cause of death, never seen before, arrived suddenly, rose in prevalence very rapidly. And the first wave of COVID-19, in fact, came and went entirely before any cases appeared in the conventional GP research data extraction data sets. Also, in addition to timely data, you also need huge numbers of patients in a research data set if you want to understand things like the differences in risks from COVID-19 in smaller subgroups of the population. So we knew that we needed very large-scale data, and that required very large volumes of patient records. And the challenge for that has always historically been public consent and professional consent. Now, campaign groups like MedConfidential, but also professional bodies like Royal College of GPs and BMA have always historically been very concerned about whether records are managed in a way that protects patient privacy. And I think they are right to have those concerns. In the past, I think we've relied very strongly on public reassurance for secondary uses of data. And I think public communication is really important, but it's also important to prove to the public that you've taken appropriate privacy steps, engineering steps to protect their privacy, and also to be transparent about everything that happens on the data. And that's because data, even when it's pseudonymized, even when the names and addresses are removed, is still readily re-identifiable. It's easy to identify individuals in the record. So we had a series of objectives when we set up OpenSAFELY. First of all, we wanted to build something that was more secure than the current offers of extraction of data and then disseminate it out to researchers to work on their own local laptops. We wanted to avoid people having needless access to view or interact with the raw data, as you see with many off-the-shelf trusted research environments. But we still wanted researchers to be able to run analyses conveniently across the most disclosive raw data. We wanted all code for data management and analysis to be shared to support open science and critical review and efficient scientific reuse. But we wanted that to be shared in a way that facilitated reuse. So what tends to happen with electronic health records research is people do enormous amounts of work on data preparation, data curation, because this is quite challenging data to work with. It's around 60 or 80 billion rows of data in total. But it tends to be done in a very bespoke way in each individual setting. And so you end up with a string of some SQL files here, people matching records or doing bits of data preparation or fixing the dates in R or Python or Stata. We wanted to have data curation and management done in a standardized framework, something that was pragmatically standardized, not restrictive, but something where the code would be visible and reusable to all users. And we also had to do it very quickly with a low startup cost. And lastly, we wanted to be completely transparent to the public and others about all actions on the data. So just very briefly to run through our two key design choices. The first is that we built a trusted research environment. So we built the analytic platform inside a secure data center. And in fact, we built it inside the data center where the data already resides. So we built it in collaboration with TPP and EMIS, who are the two big electronic health record software suppliers, who already have all of the data in one location, TPP in one data center, EMIS in one data access environment. Now, by doing that, a number of good things flow. First of all, you're already acting inside a secure setting where you've got ISO 27001 compliant environment and so on. Secondly, you get to work very closely with the electronic health record software suppliers who themselves employ lots of software developers who build the software tools that are used to record the data. So it gets you access to a close and what has proven to be extremely productive and positive collaborative relationship with the people who actually produce the data in the first place. But that's not the only security move. The second, and I think more interesting one, is that we went in some respects beyond a traditional trusted research environment. We also built a software layer on top of the raw data that obfuscates people's access whilst allowing them to run analytic code, and also standardizes the code that people use to work with the data. This all flows from one simple single move, which is we created some standard tools for data preparation to convert the raw records, one row for each clinical event, into a one row per patient data that's ready for a regression analysis or tables or visualization. Now, by creating a single standard tool for data management in that way, three things follow. Firstly, it means that all code that you create for data management and analysis can be shared for review and reuse by all subsequent users, but it can be shared informatively. It's immediately understandable and reusable to all subsequent users because they are all using the same tools for the same tasks in the same setting against the same data. And just for context, in OpenSAFELY, we have 58 million patients full primary care electronic health record. So that's not the GP extraction service data set, which is a very stripped down version. It's the full raw records. So an enormous volume of data linked onto SAS, outpatient HES, ONS death, ICNARC for ITU data, ISRIC and so on. So a huge amount of data to be understood and managed by each individual user. And we've also got users from around a dozen different locations. So we've got researchers from London School of Hygiene, and Liam Smeeth, who's speaking later, is our closest collaborator on OpenSAFELY and built it with us from the very beginning in March 2020. But we've also got researchers in now from, I think, just over 10 universities around the country, and also people from NHS England and NHSX, and we're very keen to hear from anybody who wants to come and work with us. So that standardization is powerful because it makes reuse of code much more efficient, much quicker, and that's the main reason I think why we've had a few dozen research outputs completed from OpenSAFELY, where other larger and more well-resourced projects, I think, have struggled to deliver at quite the same pace because they've not been using open collaborative working processes. But secondly, it means that we're allowed to implement some slightly more useful privacy safeguards than our traditional. So number one is we use the data management code that executes against the real data to also produce synthetic dummy data. Now, you never use that synthetic data to run your real analysis, but you use it to iteratively develop your code. So you write and tinker and produce your data preparation and data visualization and data analysis code using dummy data on your local machine. And then when you're finished, the OpenSAFELY tools check that your code is capable of running to completion. And when it is, you press a button and it gets wrapped up inside a container using something called Docker. And then your data preparation and data analysis code gets sent through into the secure environment. It runs against the real data inside that secure environment, but no researcher ever goes in there to interact with the data directly. So patients' privacy is absolutely protected. Now that's important in that it addresses privacy, but there was still a final challenge that we wanted to address, which is transparency. In the past, people have often published lists of approvals of projects, and sometimes, sadly, that still doesn't happen. But we wanted to go beyond that. We wanted to have informative public logs of all code that executes against the data. Now, that's usually not possible because analytic code is built interactively against real data. Because in OpenSAFELY, we can be confident that there is no disclosive information accidentally included in the data preparation or data analysis code. That means we can share it, and so we do. So if you go to jobs.opensafely.org, you can see live, running right now, all of the jobs that are executing against 58 million patients' records. And indeed, you can see historically all of the jobs that ever have run. And if you click through on each job, you can see the person who's running it, and you can ultimately see the raw code in the GitHub repo, because all code that executes in OpenSAFELY is shared openly for review and reuse by all. You may find that some of those GitHub repos are currently closed, and that's because we allow people, if they wish, to keep their code closed up until the point at which they publish their paper, and then everything goes open. So I think I should stop there, and I hope that wasn't too boring and geeky. But I think there are just a couple of small policy issues that are worth considering in all of this. One is, as I know I've already said 3 times, but I want to say it again, we build public trust by earning it. So comms is important, but I think we also need to have proven privacy engineering, and we also need to have transparency about all acts on the data. Secondly, open code and researchers working closely with software developers is a proven effective model. And we need to find a way to encourage funders to resource data curation, security analytics, and privacy engineering as independent high-status activities. And then lastly, I'm sure this will come up again, but the current model of 6,000 practices giving consent separately for data extractions like the one into Biobank clearly makes no sense at all. And we need to think carefully about what we can do to take the burden off GPs for making those kinds of decisions. Thank you.
Many thanks, Ben. That was great. I'm going to take a slightly different tack now, moving away from primary care data to Dr. Mark Effingham, who's the Deputy CEO of UK Biobank, who's going to talk about the research analysis platform and future data releases for the research community. So over to Mark.
Okay, thanks, Nai. So I'll dive straight in, given the short time. There's 3 things I wanted to talk about. So one was an update on our research analysis platform, which is a component part of our trusted research environment, if you like. Second, just to share some highlights from data releases over the past 12 months, but also a focus on today's 200K whole genome sequencing release, which has been touched on in earlier sessions this afternoon. And then third, just with an eye to the future, to give a sense of some of the data releases that researchers can expect over the next 12 months. So starting with the research analysis platform, and we had a detailed deep dive session on this at the last scientific conference. But for those who are less familiar, this is our new cloud-based platform to provide secure access to all of the UK Biobank data across the web. It is delivered on the DNA Nexus platform and hosted on AWS infrastructure out of the London data centre. Now, the reason why we're doing this is because really the increasing scale of the Biobank resource means we need a new model where we bring the researcher to the data, but that we also provide the necessary storage and compute that allows researchers to be able to undertake their analyses at this kind of scale. Now, at the last scientific conference, we announced that this was coming, and I'm delighted to say it is now actually finally here. And we made the platform available, generally available to all researchers at the end of September. And in the intervening few weeks, there's already been a tremendous uptick in use. We've got 900 users now using the platform, and over 300 access applications already enabled in that short space of time, which is a terrific start. Now, we do recognise that this is a shift in how researchers work with biobank data. So we've been working very hard looking at how we put in place the necessary support to enable that transition. And that starts with access to very broad, comprehensive documentation, both about the platform-specific components to RAP itself, but also the wider underlying platform that it runs on in terms of the DNA Nexus platform. It also includes a number of example notebooks and scripts that researchers can download as a starting point. And if you do get stuck for any reason, there's a really responsive help service available by email, which you can easily use. There's a number of online training materials available. So there is a regular, almost kind of weekly webinar set up. Again, you can subscribe to have those invitations appear in your inbox. It's freely open to all. But all of the content is recorded and available offline. And a number of offline webinar sessions are now there, spanning overview content right the way through to detailed step-by-step tutorials about how you achieve to do certain tasks within the platform. And then the third part is we've put in place a community portal, which we are intending to become a vibrant, collaborative environment where researchers can post questions, can share the kind of things that they're doing within the platform, best practice, and really I'd encourage any researcher, if you've not already done so, to please create a profile in that portal using the link as you can see on the screen there. So what's coming soon? There's already a number of new tools confirmed. So in the very short term, we'll be making available the OQFE pipeline, which is used to process the genetic sequence data aligned to what's been done for both the exome and whole genome sequencing within the resource. So if you have your own data that you want to import into the platform, you can use that pipeline to align those data. We're also making available the scalable GL Nexus joint calling algorithm, which is being used by Regeneron as part of the whole exome sequencing work. And again, that will be available for researchers to use with their own data. And also a Parabricks accelerated version of the deep variant tool, together with the Regeneron custom trained model that was used as part of the whole exome sequencing work, will also be coming available in the platform very shortly. And we'll be providing more information on that in due course. There are many other tools in plan, for example, support for image analytics, processing signal data, such as the wearable activity devices. But again, I'd encourage everybody, please, to post feature requests into the community portal so that we can look at what would be helpful to add as part of the development roadmap. One of those examples that's coming up very soon in the early part of next year is for the addition of the RStudio IDE, which will be another way to engage with the data in the platform. I'm sure will be familiar to those who are already working with it in their own on-premise environments, and it will complement existing Jupyter Notebook and other ways of working with the data today. And again, earlier this year, we announced that AWS have kindly made available a number of research credits, so 500,000 credits per year for the next 3 years, which will be available to early career researchers and researchers in low and low middle income development countries to put towards the cost of storage and compute. And again, that program is now live, and eligible researchers will be able to request a Getting Started credit, which will allow them start to explore and use the platform, and also request additional enhanced credits once their analysis plans become firm, and to have those costs covered. So more details on that appearing in the very short term. So turning attention to just some of the recent data releases over the past 12 months, of which there have been many. So starting with the web-based questionnaire data on pain for around 170,000 participants. We also released telomere length data for the whole cohort earlier in March, following work by University of Leicester, and also the first tranche of metabolomic biomarker data from the Nightingale assay for 120,000 participants, again in the early part of this year. Since January, we've been running a COVID-19 repeat imaging study, where we've been inviting back participants for whom we have pre-COVID data to come to undertake a set of repeat images. We've done that for 2,000 participants, so 1,000 participants for whom we know have had COVID, and 1,000 of matched controls where we know they haven't had COVID. And those data sets are pre and post-COVID data for those 2,000 participants are now available for researchers to start to understand the differences on internal organs that have been caused by this infection. And of course, there's been regular refreshes of health record data, so the death, hospital admission data, for example, and also, as we've been just talking about, the COVID-specific data around the likes of PCR tests and the GP data that have been made available for COVID research purposes. Also, though, over the past 12 months, we've made two significant releases of whole exome sequencing data. So in September, to coincide with the release of the platform, we made available 300,000 exomes. And then in October, a further 150,000 exomes from the Regeneron Consortium project. So in terms of what we have available in the platform as of now, we have 450,000 exomes, sample level data in CRAM and GVCF format. We have a joint call data set in 3 different formats, so PVCF, PLINC and BGen, and best practice guidelines about how to get the best out of these data within the platform. Coming very soon, there'll be additional flavors of these 450K variant level data, both in Regeneron's own SPV data pipeline, plus also Nomad and Illumina Dragon reprocessed data, and they will be appearing in the very early part of next year. And then to today's release, which is around the 200K whole genome sequence data arising from the WGS sequencing program, which is another industry-led consortium of 4 pharma parties, so AstraZeneca, Amgen, GSK and J&J, with support from Wellcome and UKRI. We're making available 200,000 genomes, which comprise the initial tranche of 150,000 genomes from the main phase project, plus 50,000 genomes that were sequenced as part of the Vanguard phase with funding from MRC. So today, what's available within RAP is 200,000 genomes, sample level data, both CRAMs and GVCFs, plus a joint call set of 150,000 genomes in PVCF format and supporting QC data. And then very shortly, coming soon, will be a 200K joint call set, which will incorporate those 50K Vanguards genomes. We'll be making that available in, again, the same 3 formats that we've done for the whole exome sequencing data, so PVCF, PLINC and BGen. And picking up from Carrie's talk earlier this afternoon, we'll also be making available the imputation and microsatellite data that he talked about. So then turning to my last slide, which is really on what can be expected in terms of additional data releases over the next 12 months. So seroprevalence study, where we invited 20,000 participants and their children and grandchildren to provide monthly antibody samples over a 6-month period. We've actually started a project today to go back to that same cohort to request a 7th sample, which is around about 12 months later. And all of these data, so the antibody measures, plus exposure questionnaires from each of these measure points, will be available in the early part of 2022. We also run a separate project where we have looked at antibody-based evidence of past infection by sending a device out to participants with support from Department of Health and with shipping by Amazon. And we have data for 210,000 participants, which will again be made available in the early part of next year. And that will support studies into the longer term effects of past infection. In terms of web-based questionnaires, we've got one already underway, which is a second cognitive function questionnaire, and the data on that will be available in the early part of next year. And then there are 3 further questionnaires in plan for 2022, one on long COVID, one on neurodevelopmental issues, and a 3rd on sleep. And then lastly, the proteomics assays, and again, there's been a lot of discussion on proteomics in earlier sessions. We're making available the first set of proteomics data coming from the PPP consortium, who have run the O-Link assay to measure around 3,000 circulating biomarkers, and we're making data available on initial 50,000 participants in the latter part of next year. So many more data releases to come, but which we don't have time to talk about now. So I'll end on my last slide, which is to say thank you to all of the Biobank team, but also the parties who are working with us to help generate these data, and of course to the participants without whom none of this would be possible. So thank you, and I'll hand it back to Naomi.
Thank you very much. Thank you to all the three presenters for very interesting talks. We've had loads of questions coming through on the Q&A, so thank you very much. And I'll try and get through as many as I can in the 15 minutes or so that we've got. First of all, I'd just like to introduce two panelists who joined this discussion. Clare Gerada, who's the former chair of the Royal College of General Practitioners, soon to be the new president of that organisation on Friday, so congratulations on that. And also Professor Smeeth, director of the London School of Hygiene and Tropical Medicine, and also a practicing GP who's got lots of experience in using primary care data for research purposes. So first of all, Clare, if I can come to you, we've heard a lot about, particularly in the first two presentations, about use of primary care data for research purposes. From a GP perspective, could you comment on the view from the GPs? Is data for research something that's talked about by GPs? Is this on their radar? What are their concerns about the use of primary care data for research? If you could comment on that.
Yeah, thanks very much. Fabulous thoughts, and thank you. I mean, this has been, I think somebody mentioned it, a running sword. Because of course we should be engaged in research. Of course, as citizens, we have a responsibility to share our data to make things better for our communities and our population. But the problem is the GPs hear about it really at the last moment, and we're told that this is something that has to happen. And we don't really know what to tell our patients. So we're there in a sort of vacuum of trying to explain. And whilst, of course, it goes through our professional bodies, I'm not sure it cascades right down to the ground of the GP, certainly not to the patient. So I think it was Ben that said that this mismatch between the demands for us to share our data versus the expectations in terms of what we do and our misunderstanding. So my sense, and this has been going right back to the National Programme for IT, where I was, I think that was 12 years ago, it was the same time as the Olympics got announced, so years ago. So I think what needs to happen now is we need to start engaging communities. If this has worked for COVID, it will work for everything, because if you do it on the back of COVID and explain how it saved lives because we've done it through COVID, then the public will understand. But it will only understand if we start to explain it in an honest and transparent way, as your speakers have so eloquently said.
Yeah, Michael, I wondered if you wanted to come in and respond to that, because I know NHS Digital are doing a lot of work around the public engagement piece.
I think it's very dull, because my response to that is I agree. And I think if you look at what happened last summer, we launched a programme there, and we're starting to do this. Let's talk to people about it. We didn't build the consent before we started the countdown to collecting the data. I think what we need to do this time, and what we're doing this time, is we need to have those conversations. We need to build that consent. We need to work in that trustworthy way that Ben talked about, show people that. And that's when you can press the button to say, OK, now we've built that understanding right down to the ground level. Now we can start. But that takes time.
Michael, I would also suggest, and sorry to interrupt because there's a bit of an echo, that you use bodies such as, I co-chair the NHS Assembly, which is a group of 50 individuals drawn from health and social care, carers, users, patients, managers, presidents of Royal Colleges. It is a guiding coalition for the NHS 10-year plan, and I think it's a very good space, and I know Ben came to talk to us a while back about it. It's a very good space to start to test and disseminate what you want to do.
Great advice. Thank you very much.
I wonder if I could just bring in Ben here, because I know you talked a bit about that consent was not necessary for the OpenSAFELY data, and this comes from a question from the member of the audience. Could you expand a bit on why that was the case in terms of the consent model?
Yeah, so there's a long-standing history of people working with routinely collected electronic health record data without consent. and that includes all the work that's done for service planning with HES and some work done with GP data locally, but also very large and traditional GP data extract and disseminate projects like CPRD, the GP Research Database, and various others. So working with patient data without consent certainly isn't a new thing. In fact, it has been the de facto norm for a very long time. I think where it's different from work in Biobank is that because you're working with data without consent, I think the requirement to prove to the public that you're working with their data securely is even higher. Now, of course, UK Biobank manages data securely, but where you have direct consent, I think it is reasonable to disseminate it out to individual researchers where patients have given their consent for that to happen. I think where you're accessing 60 million patient records without consent, you need to apply a much higher bar around transparency and around privacy engineering. And I think it's also really important to make a public display of how effectively you're managing those challenges. So that's really what we set out to do when we built OpenSAFELY. And I should say, I'm absolutely delighted to see such great progress on Biobank's TRE as well. And if there's anything we can do to help, we've got a lot of code that might be reusable, that might work well for you in the small corner of Biobank work that is managing electronic health record data.
Great, thanks very much. Liam, I wondered if I could bring you in on this discussion. As a researcher who's used primary care data a lot, obviously the data that goes into a primary care record, the data that come out of it is only as good as the data that goes in. I wonder if you could comment on the quality of the primary care data and whether just the coded data that researchers will have access to is sufficient for most research purposes.
Yeah, it's going to be one of those times where I say something that's kind of terribly obvious, but it took me about 20 years to come to the very firm conclusion, and that is that clinical data are hugely valuable and impressive and very high quality when and it's the data that really matters to clinical care that is really high quality. And there's sort of extra data that, for whatever reason, is collected that doesn't really influence patient care directly and doesn't really matter that much to patients. That's when you get much lower quality data. And a clear example in primary care data is smoking data, where, to be honest, what we care about is whether someone smokes or not. And it's of sort of minor interest whether they're an ex-smoker. The point is they're an ex-smoker, they've given up, so you don't want to think about it really. Now, for research purposes, it's really important whether someone's a current, an ex, or a non-smoker. For clinical data, it doesn't really matter. So what you see in the clinical data is that ex-smoking is really badly coded. And the non-smokers are a combination of people who've never smoked and people who are ex-smokers. And of course, we know this because if you look at people in clinical data, men in their 70s, for example, it's almost certain that the vast majority would have smoked during their lives. We know that. And yet most of them are coded as non-smokers because they currently don't smoke. And it's just an example of where it sounds like common sense, and sometimes it is as straightforward as that. But other areas, what you see is if the data really matter for clinical care, or they're an absolute inherent part of clinical care, such as the prescribing data, you get very, very high quality and completeness indeed. But if it's kind of ancillary data or admin data or data that isn't really going to influence a patient's care or isn't part of their care, that's when you see the drop off in quality.
Yeah, thanks, Liam. Michael, there's a question here about NHS Digital and the primary care data extract. What made you, NHS Digital, decide that now was a good time to try and crack this nut, as it were, rather than say a few years ago? Was it building on the success of accessing GP data for COVID, or was that independent of that decision?
Oh, so I mean, as some people at UK Biobank will know, this was not a project dreamt up during COVID. This has in fact been a long-running program that was delayed during COVID, and for various reasons needed to get going once things were starting to slow down. The I guess, two proximal triggers. The first one, of course, COVID showed us the importance, reiterated the importance of high quality, rapid data. Ben made the point that the first wave came and went before we saw much in the data. Frankly, the systems that existed because this project had been ready to go prior to COVID, the systems that currently exist to collect data for payments and for planning and for other fairly critical NHS research functions were out of their support. So they are legacy systems. They need to be replaced. So those are the two drivers, the importance of the data, which I think we'd all agree on, and systems needed replacing. It wasn't something dreamt up overnight.
I'm sure. And Michael, are there any plans to integrate data from private healthcare providers?
There are, yes. So we've got a program running called ADAPT at the moment, which is working with the Private Healthcare Information Network to start to bring in data from private providers. That's currently voluntary, but subject to parliamentary processes. The health bill that's going through at the moment will allow us to mandate collection for private providers. So that's very much on the cards at the moment because we know it's a gap.
Yes, thank you. So in the last few minutes, I'd like to focus my beam of attention onto Mark. There's lots of questions about the analysis platform. So one of them is whether the new analysis platform is mandatory for researchers wishing to access new projects.
So simply, no, it's not. We have chosen that the sequence data, so if researchers want to use the whole exome sequence or whole genome sequencing data, that will be through the platform, but researchers will be able to continue to work with biobank data, other biobank data within their own on-premise environments as they've done before. And we see that as being really important. I mean, to Ben's point, we have consent. We take a lot of care in how we securely share these data in de-identified form. There's a lot of talk about kind of trusted research environments, and that's not just a platform, that's all the things that we do to check that we are working with bona fide researchers, bona fide institutions, that we're supplying data securely in the context of transfer agreements, and research will be able to continue to do that with all the data other than the genetic sequence data today.
Thanks. There's one technical question here which I don't understand, but I hope you will. Is our GPU machine supported in the RAP?
Yes, they are. I mean, we're trying to build a platform that researchers will preferentially want to use. So we're really focused on how we maintain and further improve the accessibility and usability, and to make it really flexible to support a wide range of analyses. It's clearly come from a genetics kind of backdrop, but we want to support a broad range of research uses, which is part of the reason why we're trying things like including RStudio and similar. Now, underneath the covers, there is a whole range of different kind of infrastructure types that you can use. There's a rate card that's published, which you can find online, which describes all those different compute instances, which includes memory intensive, compute intensive, and includes ones with GPUs. And it will also include, if it doesn't already, the likes of FPGA-enabled instances as well. So it really is trying to provide an environment that is truly flexible to support a very broad range of research analysis types.
Great, thank you very much. So I know we're out of time, but I wondered if we can just end. Claire, if I could come back to you, if I may, to give us a final word on perhaps what you think the next steps should be, both for GPs and for the public and for researchers, to try and really move forward to make access to primary care, both in UK Biobank and elsewhere, a real success.
Thank you. Well, I mean, what you're doing now is part of it. You're engaging certainly experts, but I'm not an expert. I'm a generalist in this, but it's something you need to be engaging folk like me. I think you need to start engaging the public in very simple, understandable ways, transparent ways. My sense is you need to be, as I said before, building on the challenges and the solutions that were found for COVID, and you need to be just starting to engage with GPs and saying, and also with the area that you discussed, rather than engaging 6,000 practices, with the overarching. So in fact, because you can't engage with 6,000 practice, but it's basically communication, communication, communication. It is the right thing to do. And finally, you've got one GP here. I think you need to be getting figureheads who the public trust. Sadly, at the moment, they're not exactly trusting GPs because we're not the flavour of the month, but I suspect that will change very soon. So you need to get key GPs involved. You need to get key public and lay people involved. And just, you've got the argument. It's now about selling that argument.
Thank you very much. That's a real call to arms, and we'll certainly do as much as we can to help keep the momentum up for this extract, because it's absolutely vital, not just for UK Biobank, for all types of research that's underway. So thank you very much. Thank you to all the presenters and to the audience for all their great questions. So I'll now hand over to Rory Collins, who's going to introduce the Early Careers winner.
Thanks very much. Thank you for that, the panel. I thought before we went into the discussion about the prizes, I just wanted to thank Fergus Walsh and Fiona Watt and Jeremy Farrar for joining us to start off with and talking about the original vision of UK Biobank and what's been created since it was first initiated back at the beginning of the century. Also to thank the other funders, the British Heart Foundation, Cancer Research UK and NIHR, who are key to maintaining the core of UK Biobank. I think what you've seen today is how that core funding is really generating additional inward investment in the resource, making the resource much more valuable for all of us. UKRI particularly have been incredibly helpful in kick-starting the sequencing of the project, along with, of course, industry. And we heard from a number of the representatives from industry in enhancing the data from an assay perspective. Nightingale Health are doing NMR metabolomic assays in this, and a project is just starting with the O-link proteomic data on 50,000 of the participants, which we hope will extend beyond that initial vanguard phase, so that we do fill that gap that Carrie Stephenson talked about in the genetic section between the genetics and the disease outcomes. We've thanked the participants, and clearly the 500,000 participants are central to UK Biobank, and it's incredibly important that we keep on communicating with them and engaging with them around how the resource is used, but also, I think, how the resource can be improved from their perspective in terms of studying things that are of interest to them. And certainly that's one of the things that we hope to be able to do to an even greater extent over the years to come. But I talked about the other community at the beginning that UK Biobank depends on, the huge amount of support that we get from the research community in helping to determine how UK Biobank is built. What are the things that will make it better? You heard from Paul Matthews, who has led the imaging working group and who have helped us to work out what imaging to do and how to create those data. Similarly with genetics, an enormous amount of genetic data has been created, again, driven by the expertise of the genetic working group chaired by Matt Hurls. What more should we be doing? So, what should we be doing to make UK Biobank even more valuable for research that we're not doing? We've had people talk about eye disease at the beginning of UK Biobank that we responded to obtain information that would be relevant to eye disease. We're doing web questionnaires to get more information about exposures. And I think, again, one of the things we really want to focus on over the next few years is extending the linkages around exposures to get much more information about socioeconomic and environmental exposures of the participants, as well as, of course, linking to health outcomes through the records and getting follow-up through web questionnaires of health outcomes that aren't picked up in the record systems. So tell us what we can do to make UK Biobank even more valuable for the research that you want to do on it. So again, thank you very much for joining the symposium so far. I think in many respects we're now going to see the future in terms of the researchers. But before I do talk about the prize winners, I wanted to thank a rather unexpected source of funding of UK Biobank, a donation that we received from Elspeth Ramsey in Glasgow, who's had a lifelong interest in science and research, who donated to UK Biobank funds that are being used for the prizes for the Doctoral Student of the Year and the Early Career Researcher of the Year. Ben Faber from Bristol University's presentation of his thesis was the winner of the Doctoral Student of the Year, and thanks to Elspeth Ramsey's donation, he has won £300 worth of Amazon vouchers. The two runners-up in the Early Career Research of the Year award, also their presentations are online if you want to see them. Jessie Maxwell talking about the association between genetic risk for psychiatric disorders and the probability of living in urban settings. Again, the kind of piece of research that I certainly wouldn't have thought to do, and I think is a lovely example of the beauty of making data available for people with different imagination to use to study disease. And the other runner-up, Abhishek Nirola from the Broad Institute, who has looked at myeloid and lymphoid clonal hematopoiesis and stratified the risk of developing hematological cancers. And again, you can watch those two videos. Each of them won a £500 prize for their wonderful work. But the winner is here with me now, Hannah Mayer from the Cold Spring Harbor Laboratories, I think a relative emigrant from the UK, who's going to talk about genetic and functional insights into the fractal structure of the heart. So Hannah, over to you. Thank you very much for going in for the competition. Congratulations on winning it. And again, thanks to Elspeth for the £1,000 prize for your success. Thank you.
Thank you very much, Rory, for the introduction, and thank you very much for looking at our research and finding it exciting enough to award this prize to us. I actually want to start off with acknowledgements and saying that this was a true team effort. I called it Team Fractal Heart here. So we worked, I'm a quantitative geneticist by training, but we worked with clinicians at Imperial College London. Tim Dawes was my main collaborator here, but you've heard from Benja Bay today already, and we've had Paul Matthews chairing a session. So they were integral to the work we conducted. We then reached out to some bioengineers that could complement the work we did in the biobank to develop theoretical models that we could use to test hypotheses. And then we also reached out to some experimental biologists in Heidelberg so we could follow up on the genetic variants that we found. And yeah, so our Team Fractal Heart really allowed us to delve deeply into a question that's been around for a long, long time, first drawn or even recognized by Leonardo da Vinci, who recognized that there is this weird network-like structure in the human heart, but didn't quite know what the function of it is. And here I just have a little schematic of the heart. The part that we're particularly interested in is the one right here, which is the left ventricle. which is the left ventricle. And you can see there's this is the main heart muscle. And then in the schematic here is this indication of some rougher structure. And this rough structure is these structures that we're interested in. And here is an actual image of a human heart from the inside. So both of these white circles represent this network structure that has been discovered. But in the adult heart, we have very little understanding of what the physiological function of these structures in the adult is. We don't know much about, or we didn't know anything about their genetic architecture, and the role in diseases generally was not known at all. And here you can see we have an inside view of the human heart, but obviously in UK Biobank we're not looking at the actual hearts. We can look at imaging data of the hearts. And Venja has shown us how we can use automated segmentation approaches to take the images that UK Biobank collected. So here are short axes. So if we take images of the heart like this, MRI images of the heart, and we developed in collaboration with the clinicians at Imperial College a segmentation approach that would allow us to automatically get the borders of the heart, both the outside and the inside, because the inside of the heart borders really reflect these network structures. And then we used a box counting method that allows us to figure out how complex the surface on the inner side of the heart is. And this complexity is captured in a variable called fractal dimension. So if we keep on applying boxes of smaller, we start with big boxes and we go smaller and smaller, and we can fit a linear model to this. And the slope of this model really tells us how complex the heart is. And we applied this algorithm to imaging data from about 20,000 participants at that time. And we applied this across the heart in different sections, as you can see here. We extracted 9 sections per individual, and we registered them in a way that we can compare them across samples. And then for each of them, we get measurements. For each participant, we get measurements of their complexity or the fractal dimension. And this was our starting point for all of our investigations. And I'm just gonna show you now how we can use a triangulation approach with these measurements that we extract from the imaging data, using genetic architecture, bioengineering, and disease cohorts to really get to the bottom of what these trabeculae do. And for the genetic architecture, we ran multiple GWAS across the different sections in the heart and did a meta-analysis to get a comprehensive overview of the genetic architecture. And you're probably familiar with Manhattan plots. So we find many loci across different chromosomes that have a strong association with this complexity measure. And I've annotated a few for you here where you can see that they actually pop up for gene expression quantitative loci in either the left ventricle specifically or in the heart. They have been found associated with other heart-related measures. And then there is some candidate genes that we did follow up for in the animal experiments. And then we used additional images to non-invasively derive some physiological parameters of the human hearts. Relating back to what Venja presented to us, he was talking about the ejection fraction, and what we derived from the images was the stroke volume. So we know that within a heartbeat, the volume of blood in the ventricle and the pressure in the ventricle changes, and a good indicator for heart efficiency is stroke volume. So how much blood can the heart pump out at any given beat? And the larger the stroke volume, the less often, the more efficient the heart. And we can see that this is indicative for people with a low trabecular complexity. And when we look at people with higher trabecular complexity, we can see that their stroke volume actually increases significantly. And when we used a bioengineering approach to simulate a heart that is either smooth on the inside, so reflects people with low complexity trabeculae, or is highly trabeculated, as in this sense, we see the same shift from a low stroke volume to a high stroke volume. So we can use the bioengineering to confirm or to complement our observational data in the biobank. And lastly, we were interested in seeing whether there is any disease relevance to those. So we did some co-localization analysis in a dilated cardiomyopathy cohort and a huge meta-analysis called HERMIS for heart failure associations. We see that some loci overlap, and we then conducted a formal Mendelian randomization analysis to see whether the change in fractal dimension or complexity of the trabeculae is upstream or downstream of heart failure. And we find a very strong effect of higher complexity being protective for the heart failure phenotypes that were investigated in this study. So overall, I think having such a diverse team really allows us to bring together these different disciplines to figure out a long-standing question in cardiac biology, linking it not only to physiologically healthy phenotypes, but also to disease phenotypes. And we also, as I indicated, we looked at some animal models. So we followed up on our loci of interest. We see that even in the fish, this is a Medaka fish model, the same genes are involved. And we dove a little bit deeper as well to look at potential regulatory factors. And yeah, if you're interested to learn more about this, this is the paper where we recently published this. And again, thank you very much for giving me the opportunity to present this here and for awarding the prize.
Thank you very much, Hannah, for a lovely presentation. And again, congratulations to you and to your team for a lovely piece of work, and look forward to seeing publications emanating from you based on this work. So thank you very much.
Thank you. Bye-bye.
Thank you. I hope that anybody out there who didn't put in for the competitions, any early career researchers or PhD students, will have a shot next time round. I know there are a lot of questions that came through that haven't perhaps been answered during the panel discussion, but the team will be going through those, and we will try to get answers back to people after the meeting. And of course, you will be able to come to these sessions and watch any of them online, or if you have colleagues who weren't able to join, do encourage them to watch them online. But let me hand over now to Professor Lord A.J. Kekar, who is the chair of the UK Biobank board that's responsible to the funders to ensure that their funding is used appropriately and effectively for UK Biobank. So, A.J., thank you very much for joining us.
Well, thank you, Rory, very much indeed. And first of all, let me congratulate everybody who's contributed to this conference today. It's been a really outstanding scientific meeting, and one which I think everybody who's been associated with Biobank can be rightly proud. But I'd actually like to start my comments with going back some 20 years to those 500,000 remarkable citizens who very kindly agreed to donate their biological samples, and of course to give their consent that we might, over the following years, collect data, ultimately to bring us to this remarkable place 20 years down the line, where UK Biobank is starting to get into its stride. And that altruistic approach to life, that sense of commitment, that sense of imagination about what might be achieved by those 500,000 is something that, of course, none of us in the science community will ever take for granted or forget. But we also realise now that that commitment is a great privilege and is providing us with tremendous opportunities. And the presentations that we have seen today demonstrate what has been built on the confidence of those 500,000 participants and their generosity. A global research community with over 20,000 researchers now coming together in what must be one of the most impressive, if not the most important, biomedical research project and enterprise in the world, coming together with a deep commitment to the highest quality scientific endeavour. And the outputs to date in terms of the science have been hugely impressive. One only has to start looking at the large number of publications and the impact that those publications are already having on driving hypotheses, on initiating new research programs, and indeed the adoption of the knowledge into routine clinical practice, decision-making, therapeutic intervention, and indeed novel discovery. But beyond the scientific output, of course, the Biobank collaborative through the world has allowed us throughout the world to build new platforms, adopt, test, validate novel technologies, and of course, develop and apply advanced analytic tools. So that's all contribution to global science, to the research endeavour that we are all deeply committed to. And the opportunities will only continue to grow. The reality is, and we heard it at the beginning of the meeting, we're only just getting into our stride as collaborators in UK Biobank. And so there is much more to do. And I strongly believe, and the board strongly believe, and I know the funders strongly believe, that in the years to come, we will see the full potential of UK Biobank, a potential that really could not have been envisaged 20 years ago, and no doubt in 20 years' time, as we start to see a fuller, greater impact of this remarkable endeavour, we're going to be very clear that UK Biobank has and will continue to impact the lives of millions and millions of people around the world. And that really is a tremendous contribution, because the North Star for all of our research efforts is, of course, the patient. We do research to ensure that we can, at whichever stage in the research natural history, we are making contributions ultimately that are going to impact human health. And it's a tremendous privilege to be able to do that in a construct such as UK Biobank. As I say, none of this would be and would not be possible on an ongoing basis if it weren't for tremendous contributions and commitments from a number of individuals and organisations. Our funders, MRC Wellcome, British Heart Foundation, CRUK, NIHR, and others, of course, are industry partners, are all making tremendous contributions with their funding, with their investment in kind, but also the contribution of their insights and their commitments. A remarkable team led by Rory Collins in Oxford, our PI and Chief Executive, a really outstanding contribution by a remarkable group of people who are really impressive, not only in terms of the delivery of their project, but their deep commitment to global collaborative science. The reason why I believe UK Biobank is such a success. And then our over 20,000 researchers, those who have signed up, who are accessing the material available now within UK Biobank and applying their insights and intellects to addressing really important questions, many of which have not been addressed previously because the data, the wherewithal, materials, samples, technology, and analytical tools have not been available. But they are available now. And those deeply committed researchers are bringing their insights and intellect, as I say, to address these hugely complex but very important questions. And of course, the 500,000 Biobank participants, and of course, the many others who are contributing to make this a successful project. Ultimately, the board is responsible for the governance of the programme and for helping the senior team establish strategy and to work with the funders to ensure that the funding that is generously provided is applied appropriately, effectively, and to the greatest advantage in terms of driving the human health research effort. And that, I can guarantee, is what is happening. We are all deeply committed to ensure it happens at greater pace and scale in the years to come. I thank everybody who's contributed today and very much look forward to celebrating more milestones and more advances in this remarkable global project. Thank you very much indeed.
Thank you very much, everybody, for joining the conference. If you have a moment and you could answer the few poll questions in the next few slides, that would be really helpful about the program and the sessions. And again, thank you for all of the help that you give UK Biobank, and thank you for joining the meeting today. Goodbye.